Trabeculectomy. Thank you.
So, Dr. Rahul Prasad, I will be needing your help because I am not seeing, and Dr. Vibhuti Bhushan also, I am not seeing Dr. Poonam Singh. She is the coordinator of the Fishbowl Glaucoma. So now we are starting our JHOS.
Ma'am, I've joined.
Okay,
Ma'am,
okay,
I'm
good.
there.
Okay. Actually, you were not receiving my call, so I thought you were not there.
No, I'm
Okay,
here. I'm here.
okay. So over to Dr. Poonam Singh. She's a very senior glaucoma consultant in Tata Main Hospital, uh, Jamshedpur, and she will be introducing Dr. Sujata ma'am and Dr. Devendra. And first, we will take up the talk of Dr. Sujata ma'am because Dr. Devendra will join after him. Madam has a very beautiful presentation, case presentation. She will show cases. And okay, over to Dr. Poonam for introduction of both the faculties.
Hi, Poonam.
Hi, good evening, sir.
And then after their introduction, please introduce the chairpersons of this session and inner circle and outer circle.
Yeah, sure, ma'am.
Okay.
Okay. A very good evening, and we come towards the end of the session on glaucoma, which is a very important and very common topic also. So, I would first like to introduce our first master for the glaucoma, Dr. Sujata V. Kadambi, and she is a senior consultant in glaucoma services at Shankar Nethralaya, Chennai. She has completed her graduate medical education from St. John Medical College, Bangalore, and was judged as the best outgoing student of her batch. So she's a master in ophthalmology from Arvind Eye Hospital, Madurai, and she has done a fellowship in glaucoma from Narayana Nethralaya, Bangalore. She's a member and of the Associate Advisory Board for Young Ophthalmologists, Asia Pacific Glaucoma Society. She's also the recipient of Ruby Banik Award for Best Clinical Research in Shankar Nethralaya for the year 2022. She has several publications in peer-reviewed journals and has worked on glaucoma patient education projects. Area of interest include work on intraocular pressure and imaging in glaucoma. We are very delighted to have you today here with us, ma'am, so that our PG students are also will be benefited by your presence and your talk today. A very warm welcome to you in this session, ma'am. Uh, doc, and the next master speaker today is Dr. Devendra Maheshwari. I have met him because I was there for fellowship in Trinelveli for short glaucoma fellowship. So he's at present an associate professor and ma'am. Still, he's in Tirunelveli Arvind Eye Hospital. He has done his long-term glaucoma fellowship from there itself. He's done his glaucoma fellowship from Bascom Palmer Eye Institute in Miami, USA. He has done his observership at various top universities like Long Eye Center, University of Michigan, Ann Arbor, Wilmer Eye Institute, John Hopkins University, Baltimore, and the New York Eye and Ear Infirmary of Mount Sinai. So he's a speaker of various national and international conferences. We have heard him many times, and he's a very good teacher also. More than 85 publications are there in national and international journals. Various chapters also he has written in various books, and he is presently associated with a number of national and international studies and research work which are still ongoing also. He was awarded as best glaucoma paper award in ASCRS, AIOS, GSI, all the conferences for that matter, TNOA conference in 2022 and 2023. He invented the first indigenously developed cost-effective mixed device, which is also named after his name, Dave Dualhook. So he's a member of various societies. He's a reviewer of various journals, and he is the person with whom you can associate for many publications also. So WGO and ARVO Travel Grant Award was awarded to him. His areas of interest are MIGS, which is the in thing now in glaucoma in Asian population, especially in angle closure glaucoma, along with emerging goniotomy procedures. So, very warm welcome, sir, to this session. We have been hearing you again and again for various topics at various levels. So, very warm welcome. We are very much sure that our students will definitely be very much enlightened by your talk today.
So please first introduce the inner circle and outer circle because we are taking presentation of the postgraduate student first, and she is Pooja Tanvar from Bhagwan Mahavir Manipal Hospital. So please introduce the inner circle and outer circle and the chairpersons of the master class also. Chairpersons of master class also.
Okay, ma'am. The present Dr. Inner circle persons are Dr. Samiksha, who is from RI RIMS, Ranchi, Dr. MD Nasir Khan, RIO RIMS, Dr. Swati Kumari, RIO RIMS, Dr. Shweta Kumari, means from RIO RIMS. Then there is Dr. Amar Kumar from MGM Medical College, Dr. Mayank Sharan and Dr. Vikas Thakur. They are all from MGM Medical College, Jamshedpur. And Dr. Bhavya, Dr. Raksha, Dr. Richa, and Dr. Sana Afreen, they are from our hospital in Tata Main Hospital, Jamshedpur. Dr. Lalita Priya Ji is from Gandhinagar Hospital, CCL Ranchi, and Dr. Nupur Gupta, Dr. Tushar Dhiman, and Dr. are from Bokaro General Hospital, and Dr. Ankit Pratik is from Kashyap Memorial Eye Hospital, Ranchi. And in outer circle, we have Dr. Anamika Chaudhary, who is from RIO RIMS, Dr. Vatsala Kumar, RIO RIMS, and Dr. Nidhi Sharma from MGM Medical College, Jamshedpur. Dr. Anamika Thakur, Bokaro General Hospital, Dr. Ujjwal, Bokaro General Hospital, Dr. Gagandeep Singh Gulati, Kashyap Memorial Eye Hospital, Dr. Shubham Singh, Kashyap Memorial Eye Hospital, Ranchi, and Dr. Ishad Khan, Kashyap Memorial Eye Hospital, and Dr. Pragya Chauhan, both from the same Kashyap Memorial Eye Hospital, Ranchi. So the presentation of the PGs is by Dr. Pooja Tanvar. The topic is Bilateral Pressure Divergence, a case of marked interocular IOP asymmetry post trabeculectomy. The time allotted is 5 minutes. So let's start with her talk.
Good evening, ma'am. Firstly, we'll talk about the 5 R's. That is the scleral rim, the neuroretinal rim, the RNFL, the peripapillary changes, and the retinal hemorrhages around the disc. And as far as the other finding is concerned, the VFA. Could you change the slide, ma'am? We'll after seeing the patient details and reliability index and false positive and false negative, which would be 13% and 33%. We'll go to the GHT, that is the glaucoma hemifield test, which shows the that it is outside normal limit. Then we would see the mean deviation. Since mean deviation is there are 3 criteria. I mean, mild, moderate, and severe. So mild is mean deviation less than -6, moderate is -6 to -12, and severe is more than -12. In this case, the mean deviation is -10. So it comes to be moderate glaucoma, and the pattern standard deviation, the CPSD, is checked, and the total deviation and pattern deviation are also seen. And because after following the Anderson criteria, we'd come to the conclusion.
Okay, thanks, Dr. Vatsala. So you are right. So this is the information provided to you, and NCT IOP Van Herrig's grading. You're finding disc damage and the corresponding visual field changes, like how you correctly described, and it is fulfilling the Anderson's criteria. What I wanted to highlight is, for a diagnosis of glaucoma, just NCT IOP is not sufficient. Okay, and for diagnosis and managing a patient with glaucoma, we all know the gold standard measurement would be by Goldman applanation tonometry. So even this NCT has shown pressures of 14 and 17, something in the normal range. So before we initiate treatment for glaucoma, we need to do a day diurnal variation test or an office DVT, that is from 8 a.m. to 5 p.m. Every 2 hours, you will take intraocular pressure measurements, so baseline, to know what is the actual peak IOP of the patient and if the patient is having a lot of intraocular pressure fluctuations. Also, we need to document what is the central corneal thickness or the pachymetry of the patient. And most importantly, here I've only projected the information of Van Herrick's. Van Herrick's grade 4, it's not sufficient. No glaucoma exam is complete, or even a comprehensive eye exam is incomplete without doing gonioscopy. So you need to do gonioscopy to rule out occludable angles, to rule out any subtle pseudo-exfoliation. As I told you, normal tension glaucoma, you'll find the angles to be open angles. And also a very important fact for all of us to remember is gonioscopy is not to be performed only at the time of initial diagnosis of the patient. We need to repeat the gonioscopy periodically, because as age increases, lens thickness can increase, so the angles can get narrower. And whenever a patient has unexplained progression, you need to revisit the diagnosis and repeat the gonioscopy to recheck whether you label the patient correctly as open angle or normal tension glaucoma. So normal tension glaucoma, remember, is a features you need to elicit in the history. You need to rule out secondary causes of one-time damage to the optic nerve head, and other systemic associations which I described. Okay, so this is another case in front of you. It's a 72-year-old male with a right eye normal tension glaucoma, advanced disc damage, and visual fields progressing in the right eye, and the patient is on one medication, a prostaglandin analog in the right eye. Since the patient is already on treatment and the visual fields are progressing, the next step for you to logically think is to see if the patient is having a lot of intraocular pressure fluctuations. If that you find it in 10 to 12 millimeters range, which is kind of an acceptable range. The patient also had ischemic heart disease and was post angioplasty with stenting and benign prostatic hypertrophy and selective alpha-1 antagonist. Retrospective history taking, the patient gave a diagnosis of sixth sinus syndrome. So in this case, we subjected the patient to further cardiac evaluation. Because of his sixth sinus syndrome, we subjected him to an ambulatory Holter monitoring for this patient showed that he used to have a nocturnal dip or blood pressure also dropping in the middle of the night. Carotid Doppler showed a 20% stenosis in the external carotid artery. So this 20% stenosis may not be considered hemodynamically significant by the cardiologist, but considering that this patient has advanced disc damage, normal tension glaucoma, has other cardiovascular morbidities, and is progressing, we need to communicate the importance of this finding to the cardiologist, and they would probably consider starting the patient on antiplatelets and following up and repeating even the carotid Doppler more periodically. So this is a third case in front of you. It's a 72-year-old male, normal tension glaucoma, advanced disc damage in both eyes on 3 medications, and visual fields are progressing. Again, the first thing we want to rule out is whether diurnal variation shows that it is between 10 and 11, quite kind of acceptable. Basic cardiac evaluation, the ECG, echo, carotid Doppler doesn't show anything abnormal. The patient also gives a history of snoring. Considering this history of snoring, we subjected the patient to an overnight sleep study and found that the patient had an apnea-hypopnea index of 33:2, 33.2, which is severe obstructive sleep apnea. So in this case, it was not the intraocular pressure which was caused the worsening of the glaucoma, but the associated obstructive sleep apnea, which is also associated with impaired blood flow to the optic nerve head. So this patient improved with weight loss measures, sleep hygiene, and a CPAP therapy. This is case 4. So you have a patient like this, 56-year-old male, day DVT in the range 12 to 14. Elsewhere, he's been started on one glaucoma medication. The disc looks like this and the visual fields look like this. Can any one of the residents from the inner circle describe the disc for me? Or anyone from the outer circle as well? It's open to the house. Can you describe the disc and you tell me if the disc and the visual fields are correlating and what would be your next approach? What other investigation you would ask?
Anamika.
Well, ma'am, the disc findings does not match with the RNFL. I mean the VFA.
And that's lovely, yes.
Yeah, it could be a disorder in the visual pathway. So we'll go with the MRI also to see whether there is a tumor or something.
Excellent, excellent. So what are those? Dr. Vatsala pointed out correctly. So here you see it is more of like, say, I would describe that this is 0.7 with sloping rims, pallor more than cupping. Okay. And here the visual field defects respect the vertical meridian. So these are mimickers of normal tension glaucoma. So in what are those conditions when your patient walks into your OPD treated elsewhere as glaucoma? When would you consider to do neuroimaging? When the patient is young, they have new onset symptoms, pallor is more than cupping, it's very highly asymmetric cupping, the disc and the visual field defects don't corroborate, visual field defects are respecting the vertical meridian, and there's sudden rapid progression. Glaucoma is a very slowly progressive disease. So whenever there is a rapid deterioration in the patient in terms of the visual field, you have to go back, look again at the fundus exam. Have you missed any vein occlusion, or think in terms neurological terms? Okay, very good, Dr. Vatsala. This is another patient in front of us. It's a 67-year-old female, normal tension glaucoma on prostaglandin analog. Previously, this patient has had very stable visual fields. Suddenly, you have this kind of clinical picture. So what is this feature you see in this clinical picture, and what would be your next course of action? Can anyone else from the outer circle try?
Ma'am, there's a splinter hemorrhage there.
Yes.
So this is a splinter hemorrhage in case of a normotensive glaucoma has high chance of getting converted to a primary open angle glaucoma.
You're partially right. Okay, it is a sphincter hemorrhage, splinter hemorrhage. It's also known as a Drans hemorrhage. These hemorrhages are associated with worsening. So in this case, what are the things you would think of? You will think if the patient is worsening, you want to look for any IOP fluctuations. So you will document a day office DVT or a day diurnal variation test.
Yes, yes.
It could also be because of blood pressure fluctuations. So you will ask the patient to go back to their physician and monitor the blood pressure at multiple times of day, because that can also vary with activity and time of the day. You will document a stereo disc picture like this for you to follow up the patient in the future, apart from the basic visual field test. And although this patient has been stable, probably you were following up this patient at 6-monthly intervals or an annual checkup. Now, if everything else is normal in your this evaluation which you have done, you will consider following up the patient more closely, maybe in 3 months' time itself.
3 months.
Okay.
Yes, ma'am.
So it's important to remember that in IOP reduction in cases of normal tension glaucoma, we prefer prostaglandin analogs because that helps to blunt the diurnal IOP fluctuations better. We will avoid beta blockers because that can cause a nocturnal dip in the blood pressure. Alpha agonists are a second line. They also have a postulated neuroprotective effect. We could then consider carbonic anhydrase inhibitors, which have a postulated, they cause a improvement in the ocular blood flow. Also important to identify and treat any cardiovascular disorder. We will consider surgery in case there is progression of the visual fields despite all other factors investigated is being taken care of and that is under control, because it is finally surgery which helps blunt diurnal fluctuations best. And when we consider trabeculectomy in these eyes, we prefer to use low dose mitomycin, multiple releasable sutures, so that we can titrate the eye pressures post-op. And it's also extremely important to take precautions to avoid hypotony. Okay. So this is another case in front of us. This is a 73-year-old male, normal tension glaucoma, showing rapid progression. You can appreciate this on the GPA, which I put. The left-hand side GPA shows that the visual fields have all stabilized well post-trabeculectomy. So the take-home message is normal tension glaucoma is a continuum of open-angle glaucoma. Here, the non-IOP dependent factors or the vascular factors play a greater role. Always confirm the diagnosis with a gold standard Goldman applanation tonometry IOP reading. Do a diurnal phasing. One IOP, you cannot label a patient as glaucoma, and before initiating treatment, it's best to establish what is the peak IOP, what is the IOP fluctuations. Always do a gonioscopy. Repeat the gonioscopy periodically. Exclude secondary causes or causes which can cause a one-time optic nerve head damage like trauma, like massive blood loss, long-term steroid use. Do refer to a physician for cardiac evaluation, nocturnal hypotension, or sleep apnea as and when applicable. Prostaglandin analogs are preferred. Avoid beta blockers. And when trabeculectomy is needed, take precautions to avoid. Thank you all. I'm happy to take questions if there are any.
Ma'am, should we go to the next class, class which was there, or should we go with the questions?
Dr. Pooja? Dr. Pooja, are you here? Yes.
Yes, ma'am.
Please share your screen.
Ma'am, is my screen visible?
Yes, it's visible.
Okay, ma'am. Good evening, everyone. My name is Dr. Pooja Tanvar, DNB first year resident in Ophthalmology Department of Bhagwan Mahavir Manipal Hospital. My today's case is bilateral pressure divergence, a case of marked interocular IOP post-trabeculectomy. The guide for my today's case is Dr. Anindya Anuradha. This is the clinical background for my case. A 65 years old male came to IOPD with complaints of pain, discomfort, and diminution of vision in both eyes, right eye more than left eye 3 months ago. Present visual acuity is no light perception in right eye and 6/18 and N36 in the left eye, improving to 6/12 and N18 with correction. He was diagnosed as a case of bilateral advanced glaucoma with uncontrolled IOP despite maximum medical therapy. Past surgical history: as per patient, he has history of multiple ocular surgeries in both eyes, including vitreoretinal surgery and trabeculectomy surgery in left eye, although previous records and timelines are not available. Past medical history: patient is using all 5 classes of anti-glaucoma medication in both eyes with a history of intolerance to oral acetazolamide. Systemic history: no combs are present. Addiction and family history were nil as per patient. In view of uncontrolled intraocular pressure, despite the maximum tolerated medical therapy, the patient was counseled regarding the need of intervention. For the right eye, trabeculectomy with mitomycin C was offered as treatment options, while retrabeculectomy with mitomycin C was advised for the left eye. After discussing the risk-benefit after obtaining informed consent. A trabeculectomy was subsequently was stable and maintained as the preoperative status, which was nil perception of light in right eye and best corrected vision 6/12 and 18 in left eye. Post-operative examination revealed markedly divergent intraocular pressure between the two eyes. Now, this was the fundus photo of both eyes, as we had no any documentation of the previous surgeries. But for the right eye, we can see the media is very hazy and the disc is hardly visible or barely visible. And we can see some scar, which is probably looking like a previous old cryo scar. For the left eye, I can see it's a very highly tessellated fundus. And if I focus or I describe the optic disc, I can see the CDR cup disc ratio is almost around 0.9, which is near total cup with peripapillary atrophy. And if I can see, there's some few old laser marks also, which describes the past surgical or laser intervention. Now, this is the post-operative examination for right eye and the left eye. Eyelids were hyperpigmented in both eyes. Lashes, the hypertrichosis was noted. Conjunctiva, the superior filtering bleb were present for both of the eyes post-trabeculectomy. Cornea for right eye, descending membrane folds were noted, while in the left eye, cornea was clear. Anterior chamber was normal and of normal depth and quiet for both eyes. Iris, surgical peripheral iridectomy noted. While in the left eye, there were the two surgical peripheral iridectomy showing or giving the evidence of the trabeculectomy done 2 times in the left eye. Pupil was mid-dilated, fixed and non-reactive to light, which is as the same status as preoperatively. While for the left eye, it was round, regular and reactive. RAPD was absent in both eyes. Lens status, it was aphakic in the right eye, and there's a PCIOL in bag in the left eye. IOP was taken by the applanation tonometer. It was 3 in right eye post-operatively, while it was 30 in left eye. Now, these are the pictures of the both eyes. As we can see, the gross appearance of the right eye. It is showing, the picture is showing the hypertrichosis, as the cornea is hazy, and it's showing the mild DM folds also there. Now, if I look just below the picture, I can see the bleb of the right eye. The bleb, it was diffused, elevated, and thin-walled and reduced vascularity. The leak, the proof of leak was not there, as during the CDL test, it was negative. If I'll go for the left eye, I can see the cornea is comparatively clear to the right eye, and there is a there's the surgical peripheral iridectomy is also visible. If I see the bleb of the left eye, it is diffused, diffused, elevated, but marked vascular bleb, well formed, and no signs of leak were present, as CDL tests were negative in left bleb too. Now, the post-operative course for the right eye. The persistent post-operative hypotony with intraocular pressure ranging between 2 to 8 mm mercury during the follow-up period was noted. It was bleb description is given already. Diffused, elevated, thin-walled, superior in position, filtering bleb with reduced vascularity. CDL was negative. To see the cause of hypotony, B scan was performed, and it revealed the choroidal detachment. Management in view of the nil visual prognosis, systemic corticosteroids were deferred. The patient was managed conservatively with intensive topical steroid therapy, initially administered hourly for a week, and subsequently tapered to every 2 hourly. At present, he is using topical steroid 6 times daily in right eye. The close follow-up is maintained for monitoring the status of eye. Now for left eye, the post-operative course it is the persistent post-operative IOP elevation, which was in range of the 22 to 29 mm Hg. Repeated immediate IOP reduction on following intervention were noted. For example, digital massage. On following regular close follow-ups, it was seeing that the IOP was high as in range of 22 to 29, but it post digital massage, it was immediately in the range of 10 or 11. Same as for the Hoskin pressure response, it was there, and suture lysis were performed in different settings. If I'll describe the bleb of left eye, it was diffuse, low height, vascularized, superior, under-filtering bleb. No evidence of bleb leak was there. Management, in view of the persistent IOP elevation, even after doing the intervention, the reinitiation of anti-glaucoma was started. The anti-glaucoma started with the Bimet T, which include the bimetoprost and timolol, 1 drop daily. Bleb needling was performed only after reinitiation of the anti-glaucoma, and IOP was not achieved. IOP was ideal. Desired IOP was not achieved. Now patient is maintaining IOP in range of the 10 to 12 mmHg, and close follow-up monitoring is there for seeing the IOP.
Thank you, Dr. Pooja. And after intense scientific sessions, we are somewhat between highly enlightened and slightly exhausted. So I would request Inner Circle residents to quickly ask your questions to Dr. Pooja. Do we have Dr. Lalita, Dr. Nupur? Anyone who wants to put up question to Dr. Pooja? Dr. Vatsala, you would like to ask something?
Yes, ma'am. Dr. Pooja, I have just 2 questions. The first one is a comment actually. You said that you used all the 5 medications, anti-glaucoma medications, but according to the treatment trial of glaucoma medications, you can use at least, you use one. If it is not accurate, then you maybe combine 2 and then probably a third one, or then switch to a surgery or laser or whatever. You used 5. So what was it judicious to use 5?
Actually, okay, ma'am. Thank you, ma'am, for the question. Actually, ma'am, patient was presented to us while he was already using the all 5 classes of glaucoma. So he came to us with this status, and I put it in as a history of the medical therapy, which was giving evidence towards the maximum medical therapy failure.
Okay, and the next question I would ask is, how would you differentiate? How in a patient with marked post-trabeculectomy IOP asymmetry, how would you determine whether it was because of the bleb dysfunction or the outflow resistance, or distal to the bleb there was some problem, or was it because of the steroid response?
Ma'am, ma'am, to differentiate it that, ma'am, we have to, first of all, we examine the bleb actually. If bleb is, ma'am, it will be the appearance, over-filtering bleb will be different. It will be highly elevated, thin wall, and ma'am, it will be hanging margin, showing that it's a hyper-filtering bleb. And ma'am, if there is a, which we see that usually immediately after the surgery, due to the high inflammation in a patient, there can be a ciliary shutdown. Then because of that, it can also cause the hypotony. And then, ma'am, third, ma'am, can I?
Bleb, whether it's because of the bleb or the
Yes, ma'am.
or something, a pathology related distal to the bleb, or is it because of the steroid response?
Ma'am, steroid, I think, ma'am, steroid, according to as much as ma'am I have knowledge, I have no idea about, like, not so much idea about the effect of steroid on the ma'am. This.
Thank you.
So anyone else would like to ask question, or we move on to the experts?
One question, which laser was used during laser suture lysis? And did you classify the bleb according to the Indiana classification system?
Yes, ma'am. For the blab, ma'am, I classified the blab according to Indiana classification. For if I'll ma'am classify the right eye blab, it was ma'am height. It was height of H2, and then ma'am extension. It was diffusely according to clock arts. So ma'am extension was E2, and ma'am it was reduced vascularity. So it was V1, and then it was if I'll classify the CDL, there was no leakage, so it was S0. While for the left eye, ma'am, the classified accordingly. It was height was ma'am left kind of flat, so I classified it as the H1. Ma'am, it was same, the diffusely extended, so it was E3, and vascularity V2, and ma'am CDL was S0. For ma'am laser suture lysis, we use the ma'am, we use the red laser.
Okay, it's okay. Thank you so much. Presented very nicely. Thank you so much, and answered also very nicely. The classification, you're very thorough with it. Thank you so much.
Thank you, Dr. Pooja and Dr. Anamika and Vatsala. So let's move on to the experts. Dr. Devendra Maheshwari, please give your expert comments for the presentation.
And we have cash prize for the best discussant. So you all have to select one discussant whom you like the best, because for each session we have kept cash prizes 1,000 for the best discussant. So for glaucoma also you have to select one person.
May I ask a question to Pooja?
Yes, sir.
Pooja,
Yes, sir.
you said there were multiple surgeries in both the eyes, right?
Yes, sir.
So do you have the detail of the surgeries?
No,
Was the
sir.
buckling was done, or the VR was done, or what surgeries were done?
Sir, actually, we have no documentation. It was as per the patient was the informant, and we could get some idea only via the seeing the fundus photo while doing the examination. As we seen in the fundus photo of the right eye, that there's an old cryo laser scar was there. So we were guessing the one of the surgery involved the cryo. And sir, same for the left eye, as we have seen that
When you examine the patient, you know whether the buckling was done or not. Number one.
Yes,
Number
sir.
two, you will know that whether the patient was injected for silicone oil or not, whether silicone was further removed or not. You will see
Yes, sir.
all the scar marks there. It's so if
Yes.
the conjunctiva is scarred, so the trabeculectomy is bound to fail, right? And number two,
Yes, sir.
if there are somebody is giving so many drugs,
Yes, sir.
anti-glaucoma medications, so you have to see what is the visual field analysis. What is the visual field that is left? It is a very tubular one. You don't jump to the trabeculectomy. You have to further increase the medication. If it's nothing is, well, of course, and the last you can go ahead with that.
Yes, sir.
These are my comments.
Okay, sir.
Thank you so much, sir. Dr. Devendra Maheshwari, your inputs, please.
Pooja, nicely presented, extensive presentation. You covered everything. Just I
Thank
want
you,
to
sir.
know first what happened to your right eye. You tell what happened to left eye, but you don't mention what happened to your right eye.
Sir, right eye, sir, he is actually still maintaining the hypotony status in the range of 3 to now he is 3 to 8, and then sir the recent USG is still showing the CD. So
CD.
sir, actually it's we are focusing more on the left eye, as right eye is already sir negative PL negative. So we are trying to save the only eye that patient has. So we are still maintaining that IOP with these topical steroids only.
Okay, though they're nicely presented, but I say sometimes really we have to think about the surgery, which surgery has to be selected. So, in my opinion, really, it doesn't require the right eye to maintain, to jump into the surgery. Right eye, we can wait and watch, and you can use some kind of the cyclodestructive procedure, really in the right eye. And again, doing the trabeculectomy, especially in aphakic eye, where the previous multiple surgery has been done, really no PL. I think instead of doing the surgery into the right eye, you should more focus on the left eye. Though the left eye you nicely presented, but I don't think by the way you presented the case is nicely presented. So probably you have the either tight suture and the patient is already on multiple medication. So more likely they have the chronic conjunctival inflammation, and there's a present in your case the way you
Yeah.
the highly vascularized blade, but you difficult to understand, but I strongly believe it won't be very diffuse. I feel really this is subconjunctival scarring is more likely in the left eye, and that's why you are able to get the 10 to 12 mmHg after doing the suture lysis. And for suture lysis, really we use the green laser, not the red laser. We use the NDR green laser. We use the green laser. Okay. And I think overall is good, but keep your finding. Don't go for just theory, what written theory that is not. See your case, really what is seen. You nice, you are theoretically you're very sound. You told the classification accurately, but you should match what the theory is, that you match your clinical findings. Okay.
Yes,
So
sir.
your clinical finding is not matching what the photograph you're showing. Maybe I may be wrong because I'm seeing the one dimensional, you're seeing the three dimensional, but I feel the blood was flat in the left eye, probably the tight suture or subconjunctival fibrosis. So my take-home message is there: better we can avoid the surgery in the right eye, but left eye you manage very nicely. It's good.
Thank you, sir.
I have one question. Will it be wise to start bimatoprost post-operatively post-trap patient?
Really, no. Really, usually in post-trabeculectomy cases, we should consider the either beta blocker or the carbonic anhydrase is the ideal choice. But it's fine. Sometimes the patient is already on the 5 anti-glaucoma medication. Really, we can't give all the 5 glasses already he is using. So really, they think sometimes that some people, some of the newer thoughts are that they want to the maximum efficacy to the reduce the intraocular pressure. But I agree with you, Shweta. We should not jump into the prostaglandin analog, because again the PG analog going to cause the more inflammation and then increase the risk of the blood failure.
I think in the right eye, if the pressure was so high, most of the time what happens is if the pressure is very high and the moment you enter the anterior chamber for trabeculectomy, there's sudden decrease of IOP and then there's collateral has to happen. If it doesn't happen, it's a surprise in such a very high IOP.
Yes, sir. So I feel really if you do this in reduce the IP, giving the mannitol, do the slow decompression, we can we can achieve the good trabeculectomy. But I feel really doing the right eye, doing the trabeculectomy, it not justified actually.
True.
Because no PLI, we can do the some cyclodestructive procedure, focus on to the left eye, because probably that's the more seeing eye, as you mentioned previously, where to look for the field, look for the how much visual field is. Has to be keep in focus, and really we have to intervene first into the left eye, save the first eye, the seeing eye. That should be the more in the focus.
Sir, I have a question.
Sure.
Sir, my question is that as you said, sir, we can give this mannitol too, but sir, that patient was complaining of constant pain due to the so much of high IOP and that discomfort. So sir, if for example, if we give the mannitol to the patient, then it will decrease the IOP. But sir, if we have to give the mannitol by IV, so sir, will it be more painful for the patient to give mannitol every time that, sir, if IOP gets high?
Not every time. What he meant was just pre-op, so that the
Okay, sir.
Down and then go ahead.
Okay, sir. And then, sir, one more question, sir. If like, sir, as the retrap was not should be done in the right eye, so sir, what else I could have like approached surgically to give the comfort or relieve the patient from the pain and discomfort which was because of that, sir, so much of high IOP?
So really, in my scenario, really, I don't know the place where you're working, but my choice will be the diode cyclophotocoagulation DLCP if
Okay.
you can do. That's the best choice such cases. And really,
Okay.
if you have the more advanced center, you can some people can perform the micropulse also. Though there is a non-seeing eye, it's very costly procedure micropulse. So my best choice will be the DLCP in right eye.
Okay. Thank you, sir. Thank you, sir.
So Dr.
Thank you
Pooja,
so
what
much. Yes, Dr. Sujata. Yes,
I
yes.
just wanted to propose a question for Dr. Pooja. So from the conversation which we have had now, what factors you will consider in a patient before choosing like the different treatment options which have been told, a cyclodestructive procedure versus a trabeculectomy versus a glaucoma drainage device? What are the things which you need to consider, like post multiple VR surgeries? What are the factors you will consider in the patient before, like, which is going to indicate I will choose cyclodestructive procedure for this patient or a trabeculectomy for this patient?
Ma'am, so before choosing a patient for any kind of intervention, as much, ma'am, I learned from this, I'll see that if patient has any surgical history, I'll see if that patient is on a complete maximum medical management therapy. I will see if there is any visual prognosis. As I said, that if it is already PL negative, there was no need to do the retrap. And then I'll see the expected outcomes, as Kashyap sir said that if there was already so much of IOP, when I was trying or we were trying to do the surgery, we were causing more harm by causing the CD and during intraop than doing the benefits. So I'll look up to all of these factors pre-operatively, and then I'll choose my patient wisely for the respective intervention.
True, correct. So the vision is important. So whatever we do must be beneficial for the patient. So if the patient has a very, very poor vision potential, we would tend towards cyclodestructive procedures rather than an invasive procedure. Second is look at the lens status, whether the patient is aphakic or pseudophakic. In this case, doing trabeculectomy when there is aphakia, it's a vitrectomized eye and it's a single compartment eye. So the aqueous flows in all directions, not just in the stoma and into the bleb. So and they're more of flow of inflammatory mediators. So the chances of scarring, fibrosis, hypotony is all common. So what you saw is kind of expected in this case.
Outcome.
Okay.
Yes.
Third
Yes.
important thing is to look for conjunctival mobility. Whether the patient has had a previous belt buckle, this subconjunctival silicone oil. How will you test for conjunctival mobility at the slit lamp?
Ma'am, conjunctiva is mobile, so ma'am, in slit lamp, I can ask the patient to.
You will just put a drop of topical anesthetic,
Yes,
use
ma'am.
the cotton tip applicator,
And
see
then,
the
ma'am,
conjunctival is mobile. That's a prerequisite for doing a trabeculectomy or a glaucoma drainage device. So now in your left eye, already when trabeculectomy is done, and it's already post multiple VR surgeries. So probably a glaucoma drainage device may be an option to be considered than a retrabeculectomy. Okay. So because it's already post multiple surgeries, the conjunctival scarring is going to be extensive. The chances of fibrosis is going to be more, and you already one trabeculectomy has failed. Okay. So
Yes,
that
ma'am.
again, whatever you saw on the left eye is kind of an expected outcome. So a glaucoma drainage device may be a better option. Okay.
Okay, ma'am. Thank you, ma'am.
Thank you, experts, and thank you, Pooja. And I must acknowledge that a great presenter is one who learns from the discussion, and you have clearly demonstrated that how thoughtfully you incorporated the insights given by the experts during the just now discussion. Thank you, Dr. Pooja, and I would like the experts to tell whom to give the best discussant winner for this session.
Because
Dr. Vatsala,
yes,
Dr. Vatsala, or Dr. Chaudhary, or Ananya Chaudhary, or itself Dr.
Anamika.
Pooja, Anamika Chaudhary, or Dr. Pooja itself, because she herself was asking the
Pooja,
questions.
Pooja. It goes to Pooja.
I think
Pooja,
Pooja deserves
yes.
it.
So wonderful. This is the great thing, that the presenter herself becomes a discussant. Very good, Pooja.
Good.
Wonderful.
So you
That's
need
too
to
unanimous. That's too unanimous.
yes,
Oh my
there is
God.
a there is a CME on 3rd
Yes,
or
ma'am.
4th.
Being a first year resident, she answered really very well. Very well. Being a
Thank
first year
you.
resident, it was really a great achievement for her to answer so nicely and all the deep
Yes.
in depth.
And
Thank you.
Dr. Anamika, can you tell me the date of the CME? Is it 3rd or 4th? Do you remember? The
Where, ma'am?
Ranchi Ophthalmic Forum CME, because on that day in the CME itself, there will be distribution of the cash prizes. So Pooja also has to come. She can contact Premlata, my secretary, because I will be going to IIRSI Chennai for the conference. So Pooja, you talk to Premlata and you be present in the CME, because in CME time only there will be a award distribution of the cash prize to Dr. Amar, Dr. Anamika, Dr. Neha, and to you.
Okay.
Very nice. The presenter itself became a winner first time.
Well done.
Well done. And now over to Dr. Nitin Dhira for vote of thanks. Nitin Dhira is the CSC, ISOC, and he is the director of the Sharda Eye Hospital, is a glaucoma person, and cataract and glaucoma, and from Jamshedpur. So over to Nitin Dhira for vote of thanks. First time you came to our fishbowl session, you saw the inner circle, outer circle, the discussions. How did you feel?
It was it was a very fantastic program. Thank you, madam. Thank you, Dr. Shweta Walia, madam. And thank you, Dr. Sujata. Thank you, Dr. Devendra Maheshwari, for giving a very insightful talk. And moreover, I would like to say thanks to all the discussants. Those were very actively participating, and madam had made the presentation so well, and she was keep on asking question, because the questions were on the basic sides, and I was very happy to see that the residents were discussing. It was a very nice program. I appreciate. So thank you everyone for joining this session. Thank you, madam, for
So
including
thank
me.
you everyone, actually, and thank you Dr. BP Kashyap sir also, because he stayed till end, because everyone today supported me for one session or the two session, but nobody supported me throughout for all the 8 sessions. It is only my husband Dr. BP Kashyap supported me. So I am
मैडम आप
really
हमें भी भूल
thankful.
गए मैडम
हाँ,
हमें ही
बोलो.
भूल गए आप हमें
Are
भी भूल
Shweta
गए
Walia,
Shweta madam ka
you are the moderator. You are the
she was
moderator.
there.
I know you are awake from 5 a.m., but you are a moderator. He is just a chairperson, and he's not a chairperson in all the session. Still, he remained with us. We are the moderators. We have to be present. It is our session.
Well, then she
So,
had taken her. She was very active in all the sessions.
yeah, I know. And she texted me that she has become CSC of two big societies. Madhya Pradesh is such a big state, and she is our Women Ophthalmological Society, India, chairman-person scientific committee from this year. So she is having 2 portfolios and very big portfolios.
But I must tell you, all the specialist speakers were superb. They were the bosses, and they are so bubbling with the knowledge. Oh my God, fantastic people.
And I will
Thank you
really
so much, guys.
appreciate
Thank you so much.
these girls, the Anamika and Vatsala. They are till end taking participation in every discussion. Anamika and Vatsala, they actually deserve a special prize from Kashyap sir.
Thank you, ma'am.
Special prize. तुम लोग दोनों बहुत अच्छे हो. दोनों इस लास्ट तक रहे, एंड फिश बोल एंजॉय अगर कोई किया है तो सबसे ज्यादा अनामिका एंड वत्सला.
Yes, ma'am.
It's
Actually,
very informative, ma'am.
yeah, and it is fun also, because we keep on being interested what's coming next, what questions gonna be asked, how can I improve myself by the presentations.
I know. So Anamika and Vatsala will be having special prizes from Kashyap sir, and Anamika will be getting 2 prizes, one in the cornea and another will be the special prize.
Thank you, ma'am. It was very We collected a lot of questions that will be asked to us in our final exams
Yes,
also.
yes.
In the Viva sessions.
Yes. You are very brilliant.
Thanks.
Very brilliant. Both the girls.
Thank you.
Both the girls are gem. Okay,
Thank
thank you everyone. Thank you Nitin
Thanks,
Dira because he
everyone.
also came very late, and this is the session is very at the fag end of the day. So thank you all. Thank you so
Thank you, ma'am.
much. Thank you.
Thank you.
We have session tomorrow also. So
Thank you.
tomorrow you
Thank you,
all have to
everyone.
come.
Good night,
Tomorrow
madam. Good
also.
night.
Tomorrow कल भी प्राइज लूट के ले जाना है तुम लोग दोनों को. Tomorrow there are 3 sessions. 3 sessions. 2
And
LDP.
we will have a dinner break also. Give a
Yes.
break for dinner, yeah.
Yes. Okay, thank you. Bye. Bye everyone.
Okay.
Bye.
Bye.
Bye.